Right, welcome everyone to our quarterly transplant update. This session will be discussing navigating life with a chronic illness and facing organ transplantation. And we have several folks with us today. The usual suspects are directors for the different solid organ transplant programs, as well as Dr. Williams, who is the Associate Chief of Nephrology, and a transplant nephrologist as well. And we also have Dr. Ivkovich, who is the co-director of transplant psychiatry here at Mass General Transplant Center. And of course, Dr. Cotton, who will be giving us a brief update on respiratory illnesses. And with that, I hand the mic over to Dr. Cotton.
Great. Hello, everyone. I just wanted to give a brief update on respiratory infections as we're heading into that season. Overall, in Massachusetts, and I'm sorry for people outside of Massachusetts, this is fairly Massachusetts focused. Actually, somebody's saying that they've lost voice. Can other people hear me? Can the other panelists hear me okay? Okay, great. Thanks.
Yeah.
So in Massachusetts, it's looking right now as though influenza severity level is low, COVID-19 ED visit levels are minimal, and then COVID-19 hospital admission level is low. So that's good news. Unfortunately, go back just one slide. Only about 15% of Massachusetts have gotten the updated COVID-19 vaccine, and about 31% are vaccinated against influenza. So that's kind of a state of the art where we are, and I'm going to go into more detail. Next slide, please. Here's one of my favorite slides, which is, or figures, is the CDC influenza, how are we doing with flu? And a couple of weeks ago, I can say that most of this showed very low disease activity, and here we go with the flu season. You can see that there are high to very high levels down in the South and in California, and it will creep its way northward. So right now we're fairly minimal in New England, but we will be seeing flu. And so if you haven't had a flu shot, that's a good time to get one. Next slide, please. So the influenza vaccine is recommended for everyone over the age of 6 months. For people 65 years of age and over, we are working on we are recommending that people either get an adjuvanted or higher dose influenza vaccine. We are working on getting higher dose and adjuvanted influenza vaccines approved for transplant patients under the age of 65, but so far they're not approved for that age group. If you do have access to that, it's certainly reasonable to consider getting that. But if you can't standardly get it, then we don't usually have a mechanism to give it to you. But that is something that we are working on at the CDC. Next slide, please. So for COVID-19, many of us have followed local wastewater data to see what's happening with COVID-19, and then what will happen in the near future. And when we see a lot of COVID-19 in the wastewater or sewage, then we know that in the next couple of weeks, we'll see an uptick in disease. And there's this fabulous new website that was released from the CDC just this week for national data. Next slide, please. And here you can see updates on how we're doing with COVID-19. The darker colors are suggestive of more disease. So you can see we either have insufficient data or hard to exactly tell how we're doing maybe in New England, but you can see there's a good amount of COVID-19 across the country, sort of variable rates. Next slide, please. And that's based on the wastewater data. And then here's a slide for different regions, and you can see that in the Northeast, we had higher levels in sort of September, but those have dipped down as of October and are maybe just beginning to trend up. Next slide, please. You can follow these and you can look at these anytime, so it's pretty cool because, if you're planning a vacation or something or planning on travel, you can kind of know what you're heading into. And this is just a picture of Massachusetts wastewater data. This is readily available. I actually have one of my kids is in school and would follow this on a regular basis because he wanted to know if his school was going to be shut down. So he used to trend this just to see where things were going. You can see in recent times, our overall levels have been pretty low. And that's both in the north and south system of wastewater within Massachusetts. So hopefully things will stay relatively quiet, but we just don't really know. There's certainly brisk disease elsewhere. Next slide, please. How are we doing with cases? So of cases reported to the state of Massachusetts, you can see levels have been pretty low. And then of deaths, overall, the number of deaths associated with COVID-19 have also been pretty low in recent times, although I would argue that it's still far too many deaths at this point in the pandemic. Next slide. So in September, we on the CDC made a recommendation that everyone get an updated COVID-19 vaccine. As you can see, not even 15% of the state of Massachusetts has gotten an updated vaccine. I would hope that everyone on this call have gotten this vaccine or be considering getting this vaccine. And their family members and loved ones, people around them, should also get it as a way to protect themselves, and also the person who has undergone or will undergo transplant. And I know this is one of the questions in the chat, for people who are moderately or severely immunocompromised, which includes organ transplant patients, they can get a second dose of vaccine 2 or more months after the first dose. But because we're probably going to be doing this vaccine every fall, most likely, I'm actually recommending that for many transplant patients that you consider getting a dose. If you haven't had one already, get a dose now and then get another dose 6 months later. What we see is that vaccine protection decreases slowly over time. And so it's probably good to get a dose now and then a dose in the spring to best protect yourself. So 2 doses spread about 6 months apart. Next slide, please. Of course, if you've had COVID-19 or something like that, then you may wish to wait a little longer to get a vaccine update. And it's complicated depending on how many doses of vaccines you've had and all that. But for people who are immunocompromised, and if you've had any doses of vaccine before, if you've had at least 2 doses, then you get just 1 dose of either the mRNA vaccine, Moderna or Pfizer, or a dose of the Novavax vaccine. For people that are, there are many people that are concerned about the mRNA vaccines. I am not concerned, and I've gotten many doses myself and given them to my family members and loved ones. But for people who are concerned about mRNA vaccines, Novavax is now widely available. Apparently, from what I read at CVS, you could go into any CVS, ask the pharmacist, and it's available throughout all CVS pharmacies. It's a traditional vaccine platform similar to a flu shot. So many of you might consider that. Next slide, please. Let's switch infections. There's a different infection. Respiratory syncytial virus, also called RSV, is a major viral infection that happens pretty much every year, usually in the mid to late fall. And it can be responsible for many hospitalizations, fairly severe disease, especially in transplant patients, and up to 14,000 deaths per year in adults over the age of 65. Next slide, please. We are starting to see increases in the amount of RSV. You can see that big peak is last year when we filled up the pediatric intensive care units with RSV. And then the numbers went down, and now the numbers are trending back up again. So we do have a vaccine. Next slide, please. And now would be a really good time to get that vaccine to protect yourself. So for anyone 60 years of age and over, unfortunately, it's not approved and not available for people under the age of 60, but for people 60 years of age and over, they can get an RSV vaccine, which is in general well-tolerated, safe for transplant patients. It's not a live vaccine. So widely available at many commercial pharmacies. Next slide, please. We do recommend this vaccine for anyone with any of the conditions listed on this slide, but basically all transplant patients should probably get this RSV vaccine if they are 60 years of age or over. Next slide, please. It is available at many commercial pharmacies, not for people under the age of 60, unfortunately, because it's not approved by the FDA for that. And it should be free for people who have Medicare Part D. If you have private insurance, it may take until next year for your insurance company to decide they're going to cover it. That's actually federal policy that they're trying to change, but is currently federal policy. Next slide, please. I would still ask everyone, especially during what is likely to become a very busy respiratory viral season, either COVID, flu, RSV, many other things, to just keep going with your masking and hand hygiene. Not all the time, but we do know that masks and alcohol-based hand cleansers are really good for preventing infection. We recommend that transplant patients wear these in higher risk settings. You can certainly, we've taken away the mask policy at Mass General, but we do, you are welcome to wear a mask at any time when you are at MGH. It's now in the category of personal decision-making. And I want people to know that we do have a plan in place to start masking in healthcare settings if we reach certain community levels of viral illness. Now, one thing I want to talk about is that I still very much believe in masking and hand hygiene. But many people are wondering, when will this stop? And I think that it's reasonable to consider doing masking when it's higher risk settings, if you're going to a concert, if you're riding on public transportation that's crowded, anytime you're around lots of other people. I actually don't want to get sick. I don't want to miss work, so I throw on a mask. And I would say that for many of you, that's a good plan. If you want no risk of getting sick, you should mask quite frequently. And then if you decide that you do want to unmask to spend time with loved ones and friends during meaningful times, that's certainly reasonable as well. If you are well vaccinated with the current therapies we have, usually people do relatively well. So I think we're now in the more gray zone of, making good decisions and spending quality time with loved ones, which is also really important. Next slide, please. So bottom line, protect yourself, get the vaccines, encourage your family members and loved ones to protect themselves and protect you by getting themselves vaccinated, and just, when appropriate, keep going with masking and hand hygiene. And thanks a lot. I'm happy to have questions in the chat.
Thank you, Dr. Cotton. So we do have a couple of questions. So one person said, I was told not to get the RSV vaccine for a year after my liver transplant. Is that correct?
Yes. So we generally don't give any vaccines for the first 3 months after transplant because the vaccines don't work very well. For vaccines that we're giving every year, like flu and COVID, it's reasonable to start getting those vaccines starting 3 months after transplant. But because RSV right now is just a one-time vaccine, we are recommending to wait 1 year. When possible, if there are people who are waiting for organ transplant who are listening now, if you're 60 years of age and over, we would recommend that you get it before transplant. All vaccines work better. They have a stronger take if you get vaccines before transplant.
Thank you. Another question, follow up to Shingrix patient is under age 50.
Yes. So if you are immunocompromised or going to become immunocompromised, Shingrix is recommended for everyone 19 years of age and over. That's been a recommendation that's been out there for several years now. So that's a good one. I will say that we are seeing, and I think the other clinicians on the call will probably agree, we're really seeing a lot less shingles than we used to when people are getting the shingles vaccine. So I'm a strong believer in it. I've had my 2 doses of Shingrix. Yeah, good idea.
All right. Another question, how long after having COVID would you wait to have the RSV vaccine?
The RSV vaccine? You don't need to wait very long after COVID. If you're feeling fine, you can get the RSV vaccine.
Okay.
You don't need to wait very long.
And
If you just, so the question is, if you just had COVID, you can wait 2 to 3 months to get the COVID vaccine.
okay. And then we have, if we are fully vaccinated and had our last shot in September, should we be waiting 2, 4, or 6 months?
Every 6 months.
All right. So that was the last of our questions for this section. Oh, just to clarify, can I take the COVID booster every 2 months? And you said every 6 months, Dr.
Yeah, you
Cotton?
can get 2 doses 2 months apart, but I don't recommend that if you've had a bunch of other doses in the past. If you've had a bunch of other doses, I would just get a dose every 6 months. And there's another question, is there a recommended interval between the booster, the COVID booster, I assume, and a flu shot? No, you could actually get them at the same time, or you could get them separately. You're welcome to get vaccines together or separately, entirely up to you, personal preference. Some people want to get it all done at once, and other people want to spread it out over time. So entirely up to you.
All right. Thank you, Dr. Cotton, for this update. If you don't mind staying on a little longer just to answer the questions in the chat, we are going to move on to the main event, which is facing a chronic illness and navigating life with a chronic illness. And with that, I'm going to hand it over to Dr. Williams to speak on this topic.
Thanks so much, Stacy, and hello to everyone, and thank you all for joining us this afternoon, moving into evening. I'm Dr. Wynne Williams, and as Stacy indicated, I'm a transplant nephrologist here at Mass General. And I think this issue, facing chronic illness, is a central issue for all of the physicians on the panel here. Why? Because all of our work is focused on patients who have conditions that really operate over long periods of time. I have one comment in the chat that there's no sound. Can you guys hear me?
Yes.
Okay.
We can't hear. Yeah.
Okay. I'm not sure what that problem there is. So this is a central issue for all of the physicians on the panel. And what I'm going to do is share my observations with kidney disease as a template for multi-organ issues, and my colleagues will chime in as we move through this presentation. So just by way of chronic kidney disease, acute and chronic kidney disease is a worldwide public health problem. There's variation in what we call the incidence and prevalence of disease and outcomes by race. This may reflect differences in geography, race, and ethnicity, ancestry. There are biological factors. There's genetic variation at certain key genetic loci. For example, genetic variation at the APOL1 gene locus confers an increased risk of chronic kidney disease for African American patients. Polycystic kidney disease, another common genetically transplanted kidney disorder that it's often found in generations of families. There are socioeconomic and behavioral factors that we have to consider in terms of management of CKD, I call it chronic kidney disease, and then that hinges on access to and the quality of healthcare in various communities. Next slide, please. So one of the key messages that I'd like to convey to all of the patients in the audience is to know this, that you're not alone. So the burden of chronic kidney disease, that's one example of an organ disorder, but for all of patients, you're not alone, and kidney disease is an example, but you probably know that heart disease and lung disease and liver disease is also very common. You'll hear from our experts, my esteemed colleagues, about those disease entities. But where CKD is concerned, 1 in 3 Americans are at risk for kidney disease. 37 million people have chronic kidney disease, and approximately 700,000 people in the United States live today with kidney failure, and they require dialysis. Over 100,000 people are waiting on the National Kidney wait list for kidney transplantation, for kidney transplant. And the problem there is a multi-organ system problem. Demand far outstrips supply for organs for patients awaiting transplantation. Next slide. So I'm often asked by patients and even by primary care providers, well, what is the best renal replacement therapy? Next slide. And so dialysis is clearly a well-trod fallback for patients with advanced end-stage kidney disease. Dialysis is life-saving. And the examples I give here are hemodialysis, in-center or home dialysis, where patients' vascular access is cannulated and the blood is run through a computerized dialysis machine where electrolytes and fluids and toxins are exchanged from the patient, and volume is cleared, because generally these patients are not making urine. And so this is a way of ridding the body of excess fluid. Peritoneal dialysis is a procedure where a catheter is inserted into the abdominal cavity, and then dialysis solution is run into that cavity, and then it dwells for about 4 hours and then drained. You do that 3, 4, 5 times a day in an ambulatory, chronic ambulatory peritoneal dialysis modality. What you see in the lower panel here is a cycler, which cycles fluid, dialysate fluid, in and out of the patient overnight. So the patient wakes up after 10 or 12 exchanges and they're good to go in the morning. And the rightward figure here is a transplant patient. You see the native kidneys in their anatomic position, and then the transplant kidney is in the lower quadrant on the right there, and that's in the inguinal region, and it's attached to the large vessels coursing through the pelvis and down into the legs, the iliac vessels. And then there's that yellow conduit is the ureter. There it is. Now that's implanted into the bladder. Next slide. And so transplantation has been shown to be highly beneficial and the gold standard of choice for kidney replacement therapy. And this is a study, the only study and factoid that I'll give you this evening. This is a study that was done in 1999 at the University of Michigan and colleagues at the Brigham here in town, looking at the relative risk of death if you remained on dialysis versus transplantation. And the relative risk at 1.00, that dotted line is those patients who remain on dialysis, but the diagonal line is those patients who received a transplant. And you can see that early after transplantation, 2.84, call it 3, there's a threefold risk of mortality related to surgical misadventure, wound dehiscence, infection early on after transplant, rejection episodes. But once a kidney is well functioning and stable, at about 100 days after transplantation, the risk of mortality is equal to that to remaining on dialysis. And then if you have a well-functioning kidney transplant over time, then you have a survival benefit. So we estimate that long-term mortality rates are 50 to 80% lower among transplant recipients with well-functioning kidneys than waiting on the wait list on dialysis. Next slide. And so clearly, for nearly all waitlisted chronic renal failure patients who come to us, we recommend a renal transplant. Patients are with 24/7 physiologic kidney replacement. They're predicted to live a higher quality of life, returning to their daily activities of normal living, and there's an increase in longevity. Next slide. But there are barriers to transplantation. This can be a very complicated process for multi-organ systems. These are multi-level barriers that I've identified. I'm not going to take you through all of the indications here, but there are population, community level barriers, whether there's the burden of chronic disease in the community, the health care access for that community awareness, health literacy of that population, their health system level barriers, insurance product coverage for kidney transplant, whether there's an appropriate educational setting in a sophisticated transplant center to give information, fully inform patients of the opportunity for kidney transplantation. The healthcare provider level barriers, whether the healthcare providers have the communication skills, again, to reach out to their patients and educate them about the opportunity for transplantation, training, knowledge, cultural competence, where minority individuals may be sensitive to those sorts of contact and information. And then at the recipient donor level, this is a matter of family structure, occupational structure, socioeconomics, knowledge and belief systems in families, religious concerns. There may even be medical mistrust. Some families consider transplantation as experimental medicine. So there are tiered multi-level influences there that can be operate as barriers. Next slide. But the roadmap to transplantation, again, is somewhat complex, and it's not a trivial process. So this is where we have to have really tight partnerships with our patients to really realize the opportunity for a transplant. You have to be referred. Some patients even self-refer themselves in the first instance. And then you have to undergo an extensive evaluation process. And the evaluation process at Mass General is a day-long process when you meet many different transplant professionals in various sectors of our unit. We're looking to make sure that your heart healthy, that you're free of infection, either diagnosed or undiagnosed, free of cancer that may be occult or fully diagnosed, and if you've been treated, that you're cancer-free. In general, we just have to make sure that you're healthy enough to get through the transplant process in good fashion. We take then that evaluation to a selection committee, and we then adjudicate whether a patient is a reasonable candidate for waitlisting. Patient is waitlisted. We make sure they're ready after they've waited for 5 to 6 years in New England, depending on your blood type. And then you realize their first transplant. But after the transplant, there's still aftercare that has to be focused on, and that takes a commitment from patients as well to partner with their transplant providers to make sure that the kidney, or in this instance, a kidney is not undergoing rejection. If there is an early rejection episode, that it can be treated, and that they all are out dysfunctioning well. Next slide. So there are many challenges after one receives a diagnosis of a chronic illness. And what I want to do now is take you away from the kidney model. We'll return to that, but I'm going to ask my esteemed colleagues on the panel to weigh in about the other systems that we are considering. And we're going to begin with Dr. Bethea, who's the medical director of the liver hepatology liver transplant program here. And Emily, please. Welcome.
Thank you, Dr. Williams. And thank you to everyone who's joined. It's a pleasure to always get the opportunity to interface with all of you as patients. And so we hope you find things useful and continue to put messages in the chat. And so similar to what Dr. Williams had alluded to in kidney and other things that you hear from heart and lung, the early stages of liver disease are oftentimes silent. So patients may be entirely asymptomatic. And one way we describe liver disease often to patients is you have a liver with millions and millions of healthy cells. Let's see if you can see my hands here over time, and no scar. And with certain types of liver disease, scar starts to form over time. And sometimes that scar takes up space and the amount of healthy liver cells start to decrease. However, you're going to feel fine, and patients aren't going to experience complications of liver disease until there's sort of more scar than there is healthy cells. And with certain types of liver disease, if you take away what's driving the scar, then the liver can regenerate and people can go back to not experiencing complications. Or with certain types of disease, the liver progresses, you remain in a state where you can't recover. And some of the challenges is kind of stated here, and you'll hear as well from other panelists. Sometimes you're totally fine until you're very sick, and that's very challenging. And I think not being able to predict that trajectory or not being able to know it ahead of time sometimes makes it hard to plan and makes it hard to moving forward. And that uncertainty is very difficult. And if you go to the next slide, we're not going to focus on liver for a long period. But here you can just sort of show in a somewhat busy fashion on the bottom that there's long periods of time people can stay in different stages of liver disease. So on the far left, in sort of the bottom pink area, is a depiction of the liver. And that says pre-cirrhotic liver disease. So before you have the advanced type of scar or cirrhosis, you can remain in a state where you're forming moderate amounts of scar. Could be related to a chronic hepatitis infection, or from alcohol-related liver disease, or from iron overload, or from many different conditions that exist. And you could be in that stage from anywhere from 10 to 35 years, potentially even longer if it's stable and not progressing. As it progresses to more advanced disease, compensated cirrhosis, so having that scar even in the advanced stage, you can have that scar but still be performing all the functions your liver needs to do. That's what we call compensated cirrhosis, until a time when there aren't enough healthy cells to do all the jobs your liver needs to do to function, at which time complications develop. And the complications are sort of discussed here. But one of the challenging things in the transplant space is trying to find the time early on to meet and to know patients, but to realize that it could be weeks, months, years, until people need to even be considering a transplant. And in many cases, maybe a transplant doesn't even need to be considered if you can try and catch things early enough and halt that fibrosis or scar progression. So I will pivot to my other colleagues now, but happy as always to answer questions.
So we're going to hear now from Dr. Catherine Black, who's a transplant pulmonologist here at Mass General.
Hi guys, thank you very much. I'm thrilled to talk about this. I focus here on many of the same issues that Dr. Bethea just discussed, that with severe lung disease, there can be similarly, although I don't highlight on the slide, a period where there's a fair amount of destruction, particularly in the fibrotic lung diseases, and the person feels fine, particularly because we're very good at adjusting our activity level for what our lungs can handle. So people don't necessarily notice that they're not walking as far or doing as much until something happens and their lung function or their CT scan is looked at more directly, and it becomes clear that there's been some serious damage. And unfortunately, once you start having severe lung disease, and all of you in the audience who are living with this know this, that this is very symptomatic, that the slogan of one of the fibrosis foundations is when you can't breathe, nothing else matters. And so just getting through a day is a struggle. And the feeling of being shortness of breath always triggers a sense of anxiety. I think it's the way the brain is built. And so many of the patients that I see in clinic have been told that they're anxious because they feel like they can't breathe. And that makes it even more difficult because it's very hard to see from the outside what someone is feeling on the inside, and that how hard it is to do what seem like very simple things. In addition, there's a whole range of diseases that can lead to end-stage lung disease. Some of them progress fairly relentlessly and progressively, and some are very unpredictable. So people can be totally fine, have no disease, and develop a very rapidly progressive pulmonary fibrosis and find themselves going from apparently completely normal to need to be evaluated for transplant in a very short period of time. And some people are struggling with emphysema. They've known they've had it for years, and they're just slowly getting worse. None of these diseases have great treatments, and honestly, the symptom relief isn't terrific either. So when you're really breathless and have a severe cough, we don't have terrific tools for that, and that can be really frustrating when you go to these hospitals that say they're so great, and you say, but I still feel terrible. Why aren't you helping me? And obviously, I focus on lung transplant, but it's really hard. I think, much harder than a lot of the other transplants. It's hard on the body. The surgery is difficult. There are a lot of restrictions we put on people that don't go away, and it's really hard on the family. And so I think facing that as sort of the best case scenario for a treatment is really difficult. Next slide. As I mentioned, there's a variety of different diseases that can lead to lung transplant. So I just wanted to mention that range and point out there honestly aren't that many lung transplants done in the country compared to some of these other organs, partly because there aren't that many lungs available. But those are divided into 4 broad categories of lung disease. And by far the most transplants in the United States are done for what's called restrictive lung disease. So this term encompasses all the fibrotic lung diseases where the lungs get stiff and filled with scar, kind of like cirrhosis of the lung. And as you can see, that the percent of transplants that are done for this restrictive lung disease has really increased over the last several years. And this was the most recent analysis that was done fully is 2021. The obstructive lung diseases are mostly emphysema. Well, there are some other more rare things that can cause, and that's really a difficulty getting air out of the lungs. So the lungs get more and more hyperinflated. And to be honest, I spent time with both of these groups of patients, but I feel as though patients with obstructive disease, and again, you know who you are, feel just unbelievably bad. And it's particularly challenging for them because their oxygen level often looks okay. They just can't move any air in or out of their lungs. And so they feel like they're drowning all the time. And again, on the outside, it looks like nothing's wrong. The third category is this pulmonary vascular disease. So these are pretty rare conditions where people have high blood pressure in the lungs itself, which brings its own frustrations because most people have never heard of that. It's a small percent, but a real one. And honestly, the transplant community still doesn't have a great way of capturing how sick these patients can be. And it tends to be a group of diseases that can affect younger people, which also has its own difficulties. And then I sort of saved the best for last because cystic fibrosis is the fourth category. And as you can see, even over the last several years, the percent of transplants being done for cystic fibrosis has really gone down. And this seems to be because honestly, at least for this one condition, we just have much better medicines now. And so that's what it seems like, that these patients aren't needing transplants as often, which is really a nice bright spot in these diseases. Next. We talk about, and you'll see there's a lot more discussion of this in the kidney section, of just ways to think about. I've just presented a lot of sort of dire news about, oh, you have this end-stage lung disease and how hard it is to live with it. But there are lots of things you can do to feel better and to maximize sort of your quality of life. Obviously, I'm going to say, I'm a medical doctor, I'm going to say, take your medicines as prescribed. But particularly it's important for things like controller inhalers. If you don't take them every day, they can't do their job. And the main thing, and the take home point I hope that you are left with, is that physical activity and maintaining a level of fitness is one of the most important things you can do. Because for most of these diseases, we can't make the lungs any better, but we can help your heart and your muscles get better. And that means you can do a lot more with the same lung function. Using your oxygen as directed is really important, because your muscles and your heart just can't do what they need to do if they don't have oxygen. You're not going to get used to it. It's not going to make you get worse. I meet lots of patients that are convinced that they're worried that they will progress faster if they're using enough oxygen. But please be kind to your body. Give yourself enough oxygen. Go to your appointments, and assemble a team you trust. And what I really just meant by this is so hard to go through that you really need to think about who's the best person to help you with each part of this. So for example, bring someone to appointments who's going to ask the hard questions that you might not want to ask your doctor, or you're going to forget. Have someone who you can call when you're feeling particularly terrible, who's going to say, that's great, I just wanted to watch a movie too. Let's just relax together. So really think about not just your team of providers, but who's your support team going to be? And thinking of healthy ways to cope. Same for any disease. Ideally, not using, for example, smoking is a really bad idea if you have lung disease. So that probably isn't a good way of relieving your stress. Pulmonary rehab, a formal program, is one of the best, and in some cases, the only safe way of building your cardiovascular fitness, because they'll monitor you carefully and can help people get a sense of what is safe to do when you really are struggling with severe lung disease. In addition to the physical benefits, it also is really important to spend time with people who have both either are experiencing the same kind of lung disease that you have, or have just thought hard about how to pace yourself through your day. So when you have bad lung disease, you have a budget of energy, and really thinking about how to conserve your energy is something that the physical therapists that run these programs are trained to do. So it is one of the most successful ways to just make your life better. So pulmonary rehab is one of the really something that everyone should try and do. And then just making sure that you're plugged in with a team that you trust to think about referral for transplant. And we recommend actually simultaneous referral to palliative care, only because, again, the symptoms are hard to manage. So no matter what happens, you'll feel better if there's someone kind of going along with you, helping control those symptoms. Thanks.
Thanks, Dr. Black. We're going to move quickly to Dr. Greg Lewis, who is the medical director for heart transplantation, our heart transplant program. Welcome, Greg.
Thanks so much, Wynn, and hopefully people see my screen okay?
Yes.
Okay, great. First, I just want to compliment my colleagues who just spoke, because so many of the things were such important points about living with chronic illness, and there's a lot of commonality between the different chronic conditions that we take care of. I'll be brief. I know we're relatively short on time, but I just want to highlight some kind of heart-specific things. One is that the burden of heart failure continues to grow and is really immense at the societal level. About 2% of the population, unfortunately, is afflicted with heart failure. Those of you who are living with or have lived with heart failure are certainly not alone. We take care of over 1,000 patients a year admitted to the hospital with heart failure. And with this being such a common condition, one of the things that's a challenge is to understand, fortunately, those living with severe heart failure are a smaller group of individuals, but how can we help these patients most and understand who's going to benefit from the scarce resource of heart transplantation? And so we look for, are the symptoms that a patient has explained by their heart condition preferably in isolation? Is there procedural compatibility? Is there conduciveness to long-term thriving with a heart transplant? And as far as living with heart failure, many of the things Katie said certainly apply to the heart failure community as well. If we look at what patients are able to afford in terms of an average patient living with heart failure and how much they can increase their metabolic rate, and then we look at what different activities cost, like walking 3 miles per hour, for example, or carrying groceries or jogging 5 miles per hour. These activities of daily living that many of us kind of take for granted sometimes are actually come at a cost that's higher than patients living with heart failure can afford. And this has huge impacts in terms of quality of life. And it's something that we're very keen on trying to understand better and try to help patients with who are living with heart failure. Another thing about heart failure is that there's often an undulating course. Patients can present being very, very sick, and then they can have these huge rebounds. So how do we understand who is best to deploy these, what we call advanced therapies, like a heart transplant or an assist device, if we don't quite know whether this person's going to have this rebound where they're going to get better? And fortunately, like Katie mentioned, for CF, for heart failure, we have better and better medical therapies, device therapies to try to help people to avoid the need for heart transplant in the first place. But because of the undulating course of heart failure, it actually makes it a little bit more challenging to understand when's the time to deploy these advanced therapies. And it turns out if we use risk models, they actually don't perform very well in terms of predicting who's going to struggle and who's going to rebound when they're living with their heart failure. We do have some clues in terms of clinical stability, but in the interest of time, I'll skip those and look forward to the discussion about living with chronic illness. But it'll just leave you with the message that therapies for heart failure are improving at a dramatic rate, and our therapies for taking care of patients post-transplant are also improving. And so I'll turn it back over to the webinar. Thank you.
Thanks, Greg. I'm going to go ahead and load my last section, and I'm going to truncate that section. If you go back to the beginning of that section there, and just say that a lot of the themes that you've already heard have emerged in the other organ systems, that a silent disease process is often something that leads to a lot of stress and anxiety because patients feel asymptomatic, they're unaware that anything is wrong. This is particularly true in kidney disease. And this unawareness, this lack of acceptance that there is in fact a chronic disease process can lead to negative feelings and emotions. And I have 3 that I've listed here, but I'm going to actually turn over the podium to Dr. Evkovic to discuss these issues of denial, anger, stress, anxiety, and depression, since we want to move through our webinar here. But I will end with this shout out to a textbook that Dr. Evkovic and myself with Dr. Stern have put together called Facing Chronic Kidney Disease, a guide for patients and their families. And this book takes you through 17 chapters devoted to a lot of the issues that we've raised here, and with a special focus on psychiatric and psychological components of coping with chronic illness. So this is a shout out. We have actually many copies that are available. If you want to ask us for a copy, we can send one to you, but it's also available on Amazon if you want to make a purchase. And I think I'll leave it there and hand over the podium to Anna.
Okay. Thank you so much. I'm going to go pretty quickly. Let me just share my screen. I cannot share screen. Okay. Can we have somebody stop sharing so I can share? All right, there we go. So here we are. And I will do from current slide. Okay. Can everyone, oh, what just happened? My screen sharing is paused. Okay, I don't know. For some reason, this may not work, so I may need to ask Stacy to take over. I don't know why Zoom is not cooperating right now.
Can you please stop sharing so I can reshare?
Yeah, it's right here. There we go. Perfect. So I think all of these slides that everyone's already covered, the content that's been mentioned, I mean, it's so wonderful to hear. Just it all ties into why managing stress and fostering resilience is so important. Okay. I am a psychiatrist, so you may be coming here this evening, and thank you all so much for joining, and thank you for having me. You probably are wondering, well, you know, a psychiatrist is going to be part of the panel, so maybe we're going to talk about medications that I can take for my depression or anxiety or my challenges sleeping. And actually, I'm intentionally keeping medications out of this conversation. I don't think that medications are a very webinar-friendly topic. It's not a one-size-fits-all kind of approach. You need to really have a proper diagnosis. Not all things that look like depression are depression. And even if it is depression, it's not necessarily true that you will benefit from a serotonin boosting medication. So it just gets nuanced. So that's why we're going to talk about more universal stress management tools. And in so doing, by helping to manage your stress levels, I'm hoping you can walk away from tonight with some tools that you use. And if you use them, you will notice improvements in your sleep, improvements in your mood. Okay. And we're going to get into a little bit of the biology behind that. But I want to jump into this first slide. Thank you, Stacy, for advancing Holmes Social Readjustment Rating Scale. So for those people who are unfamiliar with this scale, it's a scale that's been developed since the 1960s by two psychiatrists. And they were looking at the records, medical records of over 5,000 patients, and they were asking these patients, again, over 5,000, which out of a predetermined list of 43 life events did you experience within the past 2 years? And based on the data that they collected, they actually came up with different weights for these stressors in people's lives. And they came up with these stress values. And so again, it was a long list of 43 life events. I only have the top 11 here, but you will see the top ranked, highest ranked stressors that anyone can experience right here on this slide. And, you know, people will experience more than one life event oftentimes. So you're adding up the different stress values. And the higher your stress value score cumulatively, the more likely that you will have a stress-related decline in your health within the next 2 years. And because of the audience on this call tonight, I just want to draw your attention to number 6, major personal illness or injury, and number 11, change in family members' health. So the topic of stress is incredibly important. And I just want us all to know on this call, we can do things to better manage it. Okay. Next slide. Stress defined, a sense of or real threat to physical and or emotional well-being, and the belief that one is not capable of coping with a threat. That latter part is key. It's often that there's a mismatch between our perceived stress and our ability to cope with that stress, and that is really what creates distress. And I want to emphasize that stress includes both positive and negative life events. So on that past slide, marriage was listed as one of the top stressors, and that's a happy event. So any big life event can be a stressor. And the other point I want to emphasize is that not all stress is bad. And I don't want you to walk away being like, oh my gosh, I'm too stressed. It's going to kill me. Okay. Stress serves us well. It helps protect us. It helps get us out of harm's way. It helps protect us from danger. The problem is that our brain does not distinguish between the wild animal that we're trying to escape, the real danger, acute dangerous situation, from chronic worries, right? And our chronic everyday stressors. So when stress becomes chronic, that's when it's maladaptive. 60 to 90%, the statistics are here, of all visits to primary care doctors are for chronic stress-related conditions, and that includes depression and anxiety. Next slide, please. Resilience, a more optimistic topic. Okay, this is kind of the yin and yang, stress versus resilience. This is the ability to adapt successfully in the face of stress and adversity. And the cool news is that the more often we practice this and respond to stress effectively, the more likely we will do so in the future. And there's a growing body of literature, including in the transplant world, looking at post-traumatic growth. So not everyone who experiences trauma and hardship develops the downside psychologically of post-traumatic stress disorder. Some people actually experience post-traumatic growth. And it's really a neat thing to witness. People will sometimes describe having greater strength, greater wisdom, greater renewed sense of spirituality. And I want you to view it almost as an equation. When stress is greater than resilience, we develop distress. So we want to do everything we can to at least keep our stress a little bit under control, lower it as best as we can, and really bolster that resilience piece to minimize our distress. Next slide, please. Here's what happens in the stress response. It all makes sense, this entire list, if you're thinking about what would happen to my body if I was trying to escape the tiger chasing me, right? You're going to have adrenaline. Your heart rate's going to increase. Your blood pressure is going to go up. The last thing you want to do when you're feeling in danger and stressed is sleep, right? That's a very vulnerable state to be in. So a lot of my chronically stressed patients will say, hey, doctor, I'm sleeping terribly. And when I try and get a sense of, well, what's going on? You know, I get a lot of referrals being like, Anna, is this person manic or hypomanic? They have a racing mind and they're not sleeping, you know, but I talk to them, they're exhausted. They just feel tired. They just can't shut their mind off. I call it the monkey mind. And they're kind of having this superficial level of sleep. They have problems falling asleep or staying asleep, or they're very easily awakened. We're more irritable when we're stressed, and our digestion works less well. So again, when we're thinking of chasing the wild tiger, what happens? Our blood is pumping to our extremities to get us to run better, and it's shifting blood away from our digestive vital organs. So we're not digesting food as well as we need to be. Next slide. And looking at the stressed brain versus the non-stressed brain. So the stressed brain is on the right, and it's appropriately colored in red because we call it the hot reactor brain. So this, I'll point out the amygdala. It's actually kind of this primitive part of the brain. And when we perceive things to be stressful, when we perceive danger, the amygdala takes over. And once it's activated, it triggers a cascade of hormonal changes in our body, including it will send off inflammatory cytokines, inflammatory molecules. And the problem with having, you know, sustained amygdala activation, sustained stress, sustained inflammation is that these inflammatory molecules actually degrade brain networks that are important for emotion regulation. So we care about chronic inflammation in psychiatry, and we're checking inflammatory markers. Okay, so it's a little bit of a catch-22. You're feeling stressed, so you have a harder time regulating your emotions, and things feel like they're kind of starting to break down. Whereas in the calm brain, we have that front part of the brain activated first, and that front part of the brain is that prefrontal cortex. We want to have nice, healthy, strong prefrontal cortices, and we want to chill out our amygdala, okay? Because when we have a stronger prefrontal cortex, we can hit the all-important pause button, and we don't think in such a reactive way. We're not so quick to react. We can kind of think in a more rational, calm, and responsive way. And this is my lightning speed presentation, and I can slow down if I need to, but next slide, please. So this is the relaxation response. And this is where we give some good news, right? Because a lot of talk of stress can stress people out. The neat thing about the relaxation response, we have a built-in nervous system called the parasympathetic nervous system that can really trigger and activate these relaxation responses. And the nickname for that is the rest and digest response. So think about it. When you're in a safe space, your heart rate slows, your blood pressure lowers, and everything else seems to be getting better. Your sleep's improving, your immune system improves, because now you could actually work on the process of healing, okay? And your digestion improves as well. Next slide. Driving the point home, the relaxation response is conceptually the opposite of the stress response, and it's elicited by many mind-body practices, including meditation and yoga and other techniques. Next slide, please. People often ask me, where do I start? meditation for beginners. Here's a list of some that I highly recommend you looking into. If you want to take a snapshot of the screen, please do. I oftentimes will tell people start with a mantra-based meditation, like a single pointed focus meditation. And that's really basically where you're not really forcing your breath to change. For some people, as Catherine Black mentioned, people with lung conditions, just say, you know what, breath triggers me. It makes me feel anxious. I don't want to focus on my breath. That's the last thing I want to do. So what I tell people is, you know what, just start with a just this meditation. And if we have time, I would love to guide people through a just this meditation at the end. It'll just take a few minutes. Other ones that I just want to highlight, the 4-7-8 breathing is very popular. I'm kind of emphasizing this one because this is one breath technique where you're exhaling longer than your inhale. And that's also a way to really get that parasympathetic nervous system activated. Okay, is really trying to prolong your exhale and make it at least equal to your inhale, but ideally twice as long as your inhale. I remember when I started doing meditation, I just noticed that my inhales were so incredibly long and my exhales were so short. And I was like, my gosh, I must be a total stress case. But with practice, it does lengthen. Okay, next slide, please. If you have one visual you walk away with, I hope you remember this. If anyone has never seen an image of the vagus nerve, I want you to remember that this is kind of Mother Nature's way of making sure we take care of ourselves, okay? Anything this big in the body has to be important. And the vagus nerve is really the key nerve of the parasympathetic nervous system. And the reason why there's so much breath work involved when people, try to do relaxation response methods is the vagus nerve does run through the diaphragm. It's not, depicted here, but the diaphragm sits just beneath the lungs. Okay, but again, for people who are triggered by breath, take a look at where the vagus nerve else goes, right? Throat, it innervates the throat. So humming, singing, chanting. One of my favorite hacks is reading out loud at night. So doing bedtime stories with children or grandchildren or reading out loud to yourself can be a wonderful way to regulate your nervous system. And if you think about it, when you are talking, when you're reading out loud, you're kind of forcing a longer exhale than your inhale. So really great strategies here. Next slide. My top 6 tips: prioritize sleep. That's always going to be number 1. Okay. Your sleep suffers, everything else suffers. We can have a whole separate webinar on sleep hygiene, okay? But one of my favorite things is no matter what, try to have as consistent a sleep schedule as possible and try to really expose your eyes to darkness. That's another separate webinar. It's talking about, melatonin and just the problems of how much light exposure we have at night. Melatonin is a wonderful antioxidant. It's incredibly important for health. It's not just for sleep. Movement is key, just like Catherine mentioned, and stay physically active and do it enough. Prolonged sitting is the new smoking. It's not great for our health. Elicit that relaxation response daily. I always say start low, go slow. Most new habits fail because people aim too high. So I'd much rather have you start with 2 minutes of meditation a day or 2 push-ups a day than bigger, loftier goals, okay? But gradually build up once you have those habits ingrained. Eat healthy foods, low glycemic. What does that mean? Low sugar. Practice gratitude, connect with others. And ideally, you do some of this in a nice nature setting or with at least a view of some nature. Next slide, please. We're tight on time, so I'll just really quickly go through this. Basically, all things being equal, a 60-minute walk in a nature setting is much better to chill out that hot reactor brain, that amygdala, than an equivalent urban walk. So there are some trees along this urban path you can see here, right, on the lower right, but you can see the very different greenery in that left-hand image. And this really cool study that just came out last year showed that people in that nature setting walk actually had their stress organ less reactive and more calm. Next slide, please. Gratitude, we're a week out of Thanksgiving, and I hope it's not just once a year that we're practicing it. Regular gratitude practice really helps to shift our focus from the negatives in our lives to positive aspects in our life. And it really helps to boost mood and lower depression and decrease stress. Quick comment on guiltitude. A lot of gratitude practitioners will say, oh yeah, well, I'm grateful for the things I have because I could have it a lot worse. That's not the gratitude I'm talking about. Comparing to other people and saying I should be grateful because other people have it worse is not a great way to practice gratitude. It's much better to take a moment at the end of your day, have a conversation with your loved ones, or if you want to make it a private thing, do it right before bedtime. Just think about moments in your day that you are grateful for and be specific and detailed about it. It can't be, I'm grateful for my dog. It has to be, I'm so grateful for that moment when Gigi jumped in my lap and she was so cuddly and her fur felt so nice against my skin. And just take a moment to relive that brief, small moment. Next slide, please. These are some great useful apps. Please check them out. I don't have a favorite. Insight Timer is one that I use often. It is free, and they give you stars for consecutive days of meditation. So I do like that one, but these are all wonderful apps. Next slide, please. When the stress is overwhelming, please, please, please don't worry alone. Talk to your doctor about getting a mental health referral. Medications and therapy can make a huge and sometimes life-saving difference. And, obviously, if you have any safety concerns or morbid thoughts, 911 is there. There's people 24/7 there to help you. Okay. Not all therapy is talk therapy. So there's a lot of people who say talking about my problems makes me feel worse. And I say, well, have you ever tried cognitive behavioral therapy? Many haven't. And that's one of our most evidence-based therapies that can really help to just quiet some of the automatic negative thoughts that develop when we're feeling depressed and that can make depression worse. Okay. And CBT is very cool. Cognitive behavioral therapy is very cool because it's also been shown not only to treat depression, anxiety, and trauma-related disorders, but also to prevent the return of some of these symptoms. So even if you're doing well, you can almost take a preventive approach and kind of get plugged in. For resources, psychologytoday.com is actually a wonderful resource because they have a search tool where you could search by zip code and then see if people accept your insurance. And you can also search by issues. So you can actually type in medical illness and you can find a therapist that has more experience and expertise working with people with medical problems. Next slide, please. Well, so I don't know if we want to do a Q&A first or if we want to do a 3-minute guided meditation.
Let's do the meditation first, and then we can get to questions.
Okay, great. All right, so let's do this. And I always want to say you're in charge. So if there's anything that doesn't resonate with you or doesn't feel comfortable, you can picture something else or have another guidance, okay? But I'm making this a minimally breath-focused meditation. So if any of you do have any lung conditions and you feel that that makes you more anxious, please rest assured that I'm not really going to be focused on the breath for this. Okay, and I'm going to see if I can activate some nature sounds, because that's the other thing. If we can't get into our nature walk, we can at least listen to some nature sounds, and that could also help to kind of calm our nervous system. If you can't hear it, that's okay. If you can hear some birds chirp, great. All right. So I want you to make yourselves comfortable. Find a seated position with your back straight and feet on the floor. You can also grab a couple cushions and lie down on the ground, whichever feels more comfortable to you. And just take a moment to close your eyes if that feels safe. And if any of the panelists want to do the meditation, feel free to turn off your video. Let's begin with arrival. Taking a nice deep breath in through your nose and arriving into the present moment. Taking another breath and settling into your chair or cushion or wherever you might be in the moment. Letting go of anything outside this space. Letting go of any obligations, any worries, any desires. Giving yourself permission to simply be here now. Nowhere to go, nothing to do, no one to be. Only here, only now. Just this. Notice your muscles relax as you exhale. And if your breath is shallow, allow your breath to move further down into your belly, if that feels comfortable. And now, as you inhale, focus on the word just. And as you exhale, focus on the word this. And again, on your inhale, focus on just. And on your exhale, focus on this. Continue to repeat this focus on just during your in-breath and this during your out-breath. Just this. We'll repeat this for a few cycles. If your mind wanders away from just this, that's okay. Just bring it gently back to the just this mantra. And when you're ready, bring your attention back to the room. And if your eyes are closed, allow yourself to open them and rejoin the group when you are ready. I hope people feel a little bit more reset. I don't know if what people noticed. Hopefully you achieved an increased sense of calm, and that took not even 5 minutes. And I hope my adrenaline from going so quickly through my slides was not transmitted into the meditation. I think there's time for Q&A.
Thank you, Dr. Ivkovich. So we do have a question here. It looks like Dr. Bethea might be answering it, but someone else may have this question too. But someone asked, is the parasympathetic response impacted in liver transplantation when the nerves are quote unquote cut to the liver? Are you able to answer that question?
Sorry, I was typing, but I could spare that. It's a little bit complex is probably the shortest way to answer. The nervous system is a really complicated system. There's the parasympathetic and then other types of nerves that exist as well. In end-stage liver disease, there's a lot of the nervous system that's impacted by having the liver disease itself. So the stretch in the abdomen, other things that get impacted that might impact your parasympathetic nervous system's baseline function. And there are things that nerves that directly do get cut when you talk about undergoing a liver transplant, and some of the innervation, the actual nerves that allow sensations that aren't there or the same afterwards. But nerves have incredible healing capacity as well. There's a number of actually pretty decent studies that show that nervous system dysregulation and negative impacts are actually more significant in the pre-transplant than in the post-transplant setting. I mean, having the end-stage liver disease affects them in ways oftentimes that are not at all related to the mechanical cutting during this surgery, but welcome input from kind of others on this panel as well. So the short answer is yes, the nerves are impacted by cutting, but not ones that should prevent any type of resumption of function afterwards, especially in regards to regenerative capacity. And a lot of the parasympathetic ones aren't necessarily touched, but there are some things that can be impacted.
Thank you. Yeah, I don't have much to elaborate in that sense, but just how widespread the vagus nerve is. And I know it is complicated and regenerative capacity of nerves. So I wouldn't worry about having diminished parasympathetic tone, if you will.
Thank you, Dr. Bethea and Dr. Ivkovic. We have another question here. What happens to cortisol levels when stressed? And also what happens to immunosuppressants?
What happens to cortisol when stressed? So it's complicated, right? I wish I could just say it's high or it's low, but oftentimes we see with chronic stress, it gets dysregulated. We all have a diurnal variation to our cortisol curve, if you will, where it's supposed to be higher in the morning for kind of that get up and go, and supposed to be lower at night. And that's an inverse relationship with melatonin. As cortisol goes down, melatonin goes up, and that's when we get to sleep, right? So it is a little bit of a complicated answer because some people actually just have kind of flattening of cortisol curves. Some people have a flip where their cortisol level is too high in the evening. But really the best you can do is your body has some wisdom to it. I know that can be shaken up a little bit when you have illness, but is really just giving your body an opportunity to heal and to kind of self-regulate and get those cortisol levels back to a more normal diurnal pattern. I hope that answers. And what happens to immunosuppressants? In terms of do immunosuppressants affect cortisol levels? I actually don't feel like I can answer that confidently, so I don't want to give you misinformation. And I think it is also a very complicated and nuanced subject.
I'd agree with that, Anna. The one thing I'd add is, talking about mind-body connection, just to put to some of the realities we face. A lot of what we are feeling has impact on what we could consider, for example, gut or GI health. You're in the forest and you see a bear and it makes you nervous and you develop diarrhea, right? It's not that something just happened to give you the diarrhea. It has to do with how we're experiencing hormones and stress and other things in our body. I will say, for example, having diarrhea can have an impact on immunosuppressive absorption. There's nothing directly with stress where we can say in X study, this is what happens, but there are things that have to do with stress and how we're processing and how it may impact other things related to our transplant care, our medicines. And so I think all of that are things we try and work individually within each team and each patient through.
All right. Do we have any other questions to ask the panelists?
There was one question regarding kidney health in the context of heart transplantation. And just to say that this is something that we see often, chronic kidney disease after a cardiac transplant, mainly related to the medications used to stave off rejection in the heart. For example, tacrolimus and cyclosporin are known to be very effective immunosuppressants, but they also have untoward effects on the kidney in terms of a long-standing kidney injury. And so the individual put the question forward, asked, is there anything in terms of lifestyle modification or other strategies to preserve kidney health? And I would say the answer to that is that you should really be in touch with a kidney specialist to help you navigate your kidney health and give you an idea of prognosis, what to expect, and then also inform about medications that might be injurious to your kidneys in the context of our heart transplant. So the bottom line is we see chronic kidney disease in all organ transplants over time, mainly related to immunosuppression, but that deserves a kidney specialist to take a look.
Yeah, and I mean, I just want to add too that when we are chronically stressed, we burn more oxygen, we create more reactive oxygen species, we create more free radicals, and the kidneys are, Dr. Williams, you would probably agree with this, especially vulnerable to oxidative stress. So any of the stuff, the tips, the guidance we give about stress management will only serve you well in terms of even a nephroprotective effect. But yes, please talk to a kidney doctor about that.
Yeah, and I'll just add to what Wynn said. We pay great attention to the kidney function tests in the post-transplant setting in the heart transplant community, and we endeavor to individualize immunosuppression therapy, oftentimes lowering the calcineurin inhibition as much as possible in order to try to preserve renal function, close attention to blood pressure, close attention to drugs that can affect renal function. So it is a very important goal in the post-transplant setting.
There's a question about, I'm going to answer this without typing. There's the impact of sirolimus or sirolimus on kidneys. Sirolimus is thought to be kidney a kidney a kidney friendly agent, I will say. It's a separate immunosuppressant. It's a separate class of immunosuppression that's thought to be renal sparing. The problem with sirolimus is that it can be used only judiciously in other transplant models, apart from kidney transplantation. And even in kidney transplants, not every patient can tolerate this medication. So it's an mTOR inhibitor, and it has its own side effect profile that can be quite complex and difficult to manage in patients. Some patients take sirolimus well without any problem whatsoever, but it's often a challenge to manage that medication.
Thank you, Dr. Williams. We have another question here. What is Guillain-Barré syndrome and related with RSV vaccine? Dr. Cotton?
Sure. So Guillain-Barré syndrome is when there can be a neurologic condition. So people can have trouble walking and they can lose strength in their arms and legs. It is associated with all types of infections, both from the infection itself, so from viruses, bacteria, specifically one called Campylobacter. And so it can be related directly from an exposure to various infections, but also to vaccines, although the rates are very, very low, and the rates with this RSV vaccine are also very, very low. So it's, when we think about any intervention, be it organ transplantation, any surgery, anything we do, riding in a car, like there's a real risk to me driving in my car to get to work. But obviously the benefits of me getting to work, at least I hope, are outweigh any risk of me driving in the car. So we would definitely favor, especially for a very vulnerable, transplant patient over the age of 60, immunosuppressed, we would think that the risk of vaccine is greatly outweighed by the benefit. But it's a good question. It's an important one. But again, I would proceed with vaccination, but acknowledging that risk of Guillain-Barré syndrome. I have never seen Guillain-Barré syndrome from a vaccine, and I've certainly given a lot of them. So it's a good question. We are very actively reviewing data at the CDC on that very topic as well. So I'm comfortable. If it helps, I've recommended the vaccine for multiple family members that I truly love, who are over the age of 60.
Thank you, Dr. Cotton. I learned something new today. So there was another question about what I assume is the tolerance protocol. I'm not sure if Dr. Williams, you can speak about this, but the tolerance induction protocol, we have a Center for Clinical Transplant Tolerance that we just opened for patients who receive kidney transplants, and it uses donor stem cells to kind of re-educate the recipient's body to then accept that donor organ. And the question essentially was, are we doing something similar for the other organ programs?
Yeah, so that question was put in specifically for lung transplantation. And Katie, I'm actually not sure about that as a model for lung transplant.
I don't know if I have to say that in general, lung is so, I would say there are lots of basic science experiments that have been done. I don't know of anyone working on donor stem cells. I just made the point that in general, we certainly have a lot of work to do in the lung world. I think I meant to add that we often borrow from organs that are more successful in their protocols. So I don't know of any active work in this, but I think if this, often when a protocol is found to work in the kidney, maybe it would work in lung. There's certainly nothing that I know that's being worked on now.
So from my understanding, I work in the periphery with the CCTT, as we call it. Right now it's just for kidney, but there is hope to expand the protocol to the other organs. I believe liver potentially is next, but definitely plans to expand it and make it the best practice for transplantation.
There's a question in the, again, not to type now, in the Q&A, just to be efficient. What are the bad effects of sirolimus? I'm on it for my kidney transplant. If you're tolerating the medication well, that's great. There are no bad effects per se that I would say generally are associated with sirolimus. It's often just difficult to tolerate for some patients. Some patients develop rash as a function, as a result of the medication. They can develop aphthous ulcers, and it can be just very difficult to tolerate. There are metabolic effects of mTOR inhibitors, sirolimus, mainly having to do with hyperlipidemia, so high levels of cholesterol, and associated low density lipoproteins. The LDL is the bad cholesterol. You can have elevations in triglycerides, total and LDL cholesterol as a result of sirolimus, and those levels can be quite high. So they need to be addressed with other medications to counteract hyperlipidemia. The bottom line, though, if you're tolerating this and you've been on it for some time, there's no problem in taking it.
All right, so we are actually a little over 10 minutes over. So we have 2 more questions. I think we should.
It's clear that this webinar could run for 2 hours. So.
Dr. Bethea, there's a question. Can you please elaborate on this protocol for liver patients?
Yeah.
I'm
Yeah,
assuming
so I think they've talked about it starting in kidney transplant patients and liver patients. One of the beauties of liver is it's a very large organ, and unlike some of the other solid organs, fortunately, we don't oftentimes have to use as much initially in the way of kind of induction therapy or chronic immunosuppression, because it's kind of able to absorb some of the antibodies and other things that can cause rejection. Is it kind of being a large organ having some of the itself? In regards to the tolerance protocols, however, things are very early. And I think when we talk about specific patients and other things that are going on, we want to make sure that things are done in a stepwise fashion after learning from kidney. Again, this will probably be something that's happening earlier on in transplant for patients, and so not in post-transplant patients, for example, that have experienced recurrent rejection and other challenges. That's not the patient kind of population who would be initially happening, but in patients in whom, you know, early on post-transplant, we could think about expanding once we're learning more in the kidney space.
You know, I would just add that these are very promising and exciting protocols, but they're also highly experimental. You should just know that.
I'd like to second what Dr. Williams just said. I think that they are highly experimental in kidneys, and I don't know that we will get there anytime soon in other organs, maybe liver, but I think thoracic, like heart and lung, are a ways away from what I know. So We are hopeful. We had the creation of a wonderful tolerance center this year, which is super exciting, and we are optimistic, but right now we wouldn't do anything too differently. Just waiting on information.
Finalize that with the comment that the goal is always to have patients on the minimum amount of immunosuppression that's keeping the transplanted organ safe. You know, we want you on the minimum amount with minimum side effects or long-term risks associated with it. At the same time, trying to be too aggressive about coming off has very different risks, especially in relation to rejection that then is hard to get back into control or can compromise us being able to keep that organ healthy long-term. And so that's, I think, alluding to the not jumping into tolerance things too early, and definitely a lot that we're still trying to learn in that space.
There's a question in the chat about hair loss and thinning with tacrolimus, and the statement is that can be very stressful. Any recommendations for management? Tacrolimus is known in some patients to cause alopecia, hair loss, and it can be actually cosmetically very upsetting for patients. One thing that we have done traditionally is to switch immunosuppression within the same class, as Greg indicated, Dr. Lewis indicated. This is a calcineurin inhibitor class of medication. Switching from tacrolimus to cyclosporin has been one strategy, and cyclosporin tends to promote hair growth. And so that would be one strategy, but I think the thing to do is to raise that with your transplant specialists, and also think about consulting a dermatologist. A high-risk dermatologist in our center often sees these cases. So there are a number of strategies in terms of other agents that might promote hair growth, but the basic immunosuppressant that you're on can also be adjusted.
It sounds like, I don't know if any of the other programs use it, but there's some data on Envarsus not having some of the peaks and troughs. So if you do have to stay on tacrolimus, but maybe on the long-acting form, of course, there can be insurance challenges with that, but that some patients who have switched from TAC to Envarsus and had some more success there.
Yes, I've actually done that too. Yes. Yeah. There's a question somewhat related to the stem cell pre-transplant exposure to donor cells. Is there evidence that receiving a living donor liver transplant from an adult child that one has carried in pregnancy equals a lower risk of rejection than an unrelated donor? That's a pretty complicated question. I'll let Emily, you can take that one on. I don't know if you see it.
I'll try and do my best here. The pregnancy piece is another layer. In general, there are some discussions on lower risk of rejection in living donor but there's also the counterpoint of some, in certain subsets with certain characteristics, increased risk of rejection. So I think the short answer is yes, maybe, but not enough to say that, doing it is better or worse for that particular reason. It should be living donor versus deceased donor, or both, options for both based on the patient. And this is one small component of that decision.
So we've gone now for a good, I guess, hour and a half or so, and we're going to have to wrap up the session. The last question I'll answer: do you ever treat hair loss with minoxidil in pill form? I tend not to do that. You can topical minoxidil has been used. Minoxidil in pill form actually is a pretty potent hypotensive, antihypertensive agent. And so you have to be careful. And there are also side effects with oral minoxidil. I suppose some people have tried that, but I haven't personally.
All right. Well, thank you, Dr. Williams, for answering that last question. And thank you to all the panelists for joining us tonight and staying over. Like I said, this recording will be available on our YouTube page sometime next week. I will send out an email once it's ready, and I'll also post it on social media. So please be sure to follow us on social media. And with that said, thank you guys. Have a nice night. And please remember to complete the post survey after this event. Okay, good night, y'all.
Thank you to everyone.